Okay. I think we're ready to go, and I have some bad news for the panel. We were given an additional 40 codes yesterday. No, I'm just joking. No, I'm just joking. So we're almost done, actually. So we are on item, I believe it's 86, and that's the new category that we've, solid tumor-related tests, new relative to the past category, not like new category of codes. Anyway, so the next item, 86, is 0083U, and it's another oncology code, and it's response to chemotherapy. And this was reviewed by the subcommittee B as in boy, Dr. Chandra. So I'm going to turn it over to Dr. Chandra.
Thank you, Karen. We looked at this code, and it is 86. We're talking about 83U, and we did not find an existing CPT code that was suitable enough for a crosswalk, so our recommendation is to gap fill.
Thank you. Dr. Basalski, do you have any comments before I turn this over to your colleagues here in the room?
No comment.
All right. Any comments here from the folks in the room? I just want to check with my DAS folks. We don't, there is no lab, no ALM for this. No, we don't know who the lab owner is for this. This is what I have in my notes. Okay, great. So there no ability to ask them questions. So do the folks here have any other questions for Dr. Chandra's subcommittee? Any suggestions? Okay, so I'm going to go to the ballot item slide. So for code 0083U, your choices are gap fill, recusal, et cetera. I'm going to go on to the next code, 87, item 87, and the code is also 0087U, and I'm going to turn this over to Dr. Chandra, who is from subcommittee B as in boy.
Thanks, Karen. And this CPT code represents a cardiology heart transplant test, messenger RNA profiling of by microarray of 1,283 genes. Again, we were not able to identify an existing CPT code that was suitable for crosswalk, and hence recommend to gap fill.
Any comments from Dr. Baselski?
None.
Any comments from the folks here in the room? No questions for the owner of the lab? We're going to go, so I see none. Okay, so we're going to go to the ballot items slide. So for code 0087U, we have gap fill. So our next code is item 88, and it is 0088U, and I'm going to turn this over to Dr. Chandra from Subcommittee B.
Thanks, Karen. This is a test in transplantation medicine for kidney allograft rejection, where microarray gene expression profiling is utilized, profiling of 494 genes. Again, we could not find a suitable enough CPT code to crosswalk, and therefore recommend gap fill.
Thank you. Dr. Baselski, any comments?
None.
Thank you. Any comments from the folks here? Any questions for the owner? None? Okay, so we're going to go to the ballot item. And so for code 0088U, your choices are gap fill. Next item is 89, and the code is 0118U. And I'm going to turn this over to Subcommittee C. This is a transplant medicine code, and Dr. Clark.
Yeah, so the first code we have is for analysis of cell-free DNA to look at donor versus recipient in a transplant to assess risk of rejection. Our recommendation is the 81420, which is similar to the cell-free DNA for maternal fetal looking for abnormalities. We thought that technology and method would be similar, but we know that the analysis was different. And so for us, the alternative was not the 81595, but gap fill instead. So our first line recommendation is 81420. And if that's not a good fit, then we felt it should be gap filled.
Thank you. Dr. Baselski or Chandra, any comments? Any supporting recommendations?
None.
No comment.
Dr. Bossler?
I just wanted to make a comment that 81420 is actually, I think, a nice crosswalk recommendation. You're dealing with kind of two entities, donor, recipient, maternal, fetal, that overlaps well there. So I like that.
Any other comment from the members of the panel here? So we're going to then go to the ballot items slide, since I see no other placards going up. So for 01118U, the crosswalks are 81595, 81420, and of course gap fill. And then last but not least, we go to the final code for review. That is 8XX0X. And to close this, we're going to turn this back over to Subcommittee C, Dr. Clark.
Okay, so our recommendation here was crosswalk to 81229. It's a different application, but a similar method and similar work required.
Any comments from Drs. Chandra and Baselski?
Agree. 81229 appears to be a good crosswalk.
Any comments from the folks here in the room? All right, hearing, Dr. Schoonmaker?
Just one question. 81229 is an add-on to 81228. Does that make a difference? Or it looks like it is.
I don't
It's on page 556. You know how
think
it's
it's a
indented.
standalone.
Does it need to?
So some of the committee members believe this to be a standalone code. And they're checking.
Okay.
Yeah, I think from that perspective, you know, we could reconsider it. I think that this was recommended by multiple places, and so when we looked at it, it seemed to check out. But I agree that's an important question to answer.
Thank you. Dr. Chandra or Baselski?
I do believe 81229 is a standalone code, but obviously we have to corroborate that.
I agree, it's a standalone code.
Okay. Dr. Chappelle, we have multiple people here. So we have 4 out of the 14 who believe it is standalone, and unfortunately, I don't have access to the RUC database to confirm this.
Yeah, the way this is identified in CPT, it's a family member to 81228, but it's an independent code.
Okay. It
Yeah.
was indented.
Yep.
All right. So, any other questions? All right. So, for the ballot item slide for 8XX0X, the crosswalk is 81229, and then, of course, gap fill. All right, so we have completed the review of 90 codes, and I just wanted to thank the panel, and then also the folks who traveled here to help answer questions. I wanted to say thank you very much. It is a huge help for CMS to hear your perspective and provide the opportunity for the panel members to get answers to their questions. So thank you very much for those of you who traveled. I'm going to, I don't think we need another break, so, because we just came off of lunch. So I'm going to turn this over to Sarah for ATP. Hold on a second. So we're going to take a 5-minute break because we are waiting for the division director to leave one meeting and come down to the auditorium. So we're going to take a 5-minute break. Sorry, guys.
Yes, I was gonna say my dead body. Cool. Yeah.
Good thinking. That's why you said. Good selection. Keeps. Alleghenies, maybe? Yeah.
It's the upper Allegheny, so like their temperature range has been 80 to 66 right now. So it drops at night. And it's nice, cool, like clip weather.
Clip weather.
Virginia.
It is a change.
Yeah, I wish.
I'm like,
I am not that good at mine. I have enough outstanding ones in my own shop that I haven't done yet. So. I saw things like, oh, you know, all the seats have to take a picture. Yeah, but she sees it concur or something. Put it in, yeah, a couple of the camp chairs. All the actual receipts. A little bit of
you carry it all with you.
jam in my pocket. No, I don't care. If it's a cloak. Yeah.
It's a coat rack, maybe. Little port, little
Especially when you travel, it's like, well, I took off at noon, but I also landed at noon, so how does this count as lunch and dinner? Yeah. Yeah, so
There's almost a little, yeah, look at that. It's got a little
literally the car won't start.
colors were,
It's candles. Right.
so we're gonna take you back to the terminal. All deep clean. Sure. Bigger. It doesn't want you to, it doesn't really want you to find that at all? Yes.
Yeah, they would
Near
just have me
him.
come back. It's like, oh,
Ramon's
we're
me.
still doing it.
Dana, DTREVAS at Comcast.
And they hadn't called, probably hadn't like called for the backup line.
No, that's okay.
this entire time.
Yeah, I mean, they had put us over to another, no. They had rebooked
Actually, I wonder if there are other flights out of here. Yeah. Right, yeah, get Charlotte Center, yeah. Right.
And so, you know, I called, I texted her, emailed her, and
Yeah.
like, who am I supposed to be talking to? And then I was on the phone with Catherine.
Right.
And they completely rebooked my time, they came back and
Just different airline completely on.
no, it was still on American.
Okay.
It took me on a direct flight from Huntsville to
Okay.
Washington.
Oh,
and that-
okay.
And then so the voucher for it was to take a cab.
What's going on?
Which was over.
Right. But the scheme of things, it gets you here, otherwise you're not gonna make it.
Yeah, and I thought it's got walls. That looks perfect. You have to get that on the screen. It looks like some cat about
So you put a good 12 hours.
it's already
in,
got all the
or
covers.
14 hours probably.
So there you go, and you can
Travel
hook stuff up in there.
That's brutal.
Yeah.
Or something.
So Karen appropriated and said,
So maybe you should bring some little,
didn't get upset yesterday.
yeah, the little insects, exactly.
Oh, yeah. Especially for them, it's like, they can't, they have no control.
I'll make it
Airline-
Oh, yeah,
And I've learned that it doesn't matter if you get upset or not.
No.
There's
Let's see more, let's see more pictures.
nothing you can do about it.
So it folds up into a little.
And I certainly don't.
Right.
So what's another $100, right? Well, wait, it has a door on one side.
Sometimes I
Kind of helping cover the door.
Yeah.
Yeah.
I can either not put that so I won't cut a slit. I had a meeting last week outside of Chicago, and I got back to the airport, and I'm like, I hope you'll take an earlier flight. There weren't any directs, which I had a direct, so I was like, well, I'm just stuck for like 4 hours. I'm not just gonna fly somewhere just to be flying. So I walked the entire perimeter of O'Hare Airport.
Those tiny little ones from IKEA.
A little over
Remember
5
the-
miles.
You know,
just
those little things
just to
from
give myself
IKEA?
something
The
to
little
do.
Oh my
bitty
God.
I had 4 hours, 4 hours to
Essentially
kill.
the
It's
So
like,
all the airlines, you went?
yeah, I got through all,
It's
you
like
can reach all terminals now,
Tuesday, I'm gonna.
except for the international,
Yes.
you get on a bus. I was
would
like, I'm not gonna chance this and have to go through security again or
Yep.
something.
Something
Exactly.
Yeah, I just kept making rights the entire way through, and about an hour and a half to 5 miles. Yeah, that's what I was.
Okay,
yeah,
so the game plan is we're going to move ahead, and then as the division director is freed up, she will come down and participate in the discussion. I'm going to turn this over to Sarah Harding.
Okay. Thank you. So
The goal now is to continue with the conversation we started yesterday around these automated test panels. Hopefully you all had some time last night. I know you spent every minute reviewing the slides that we had yesterday. The public comments were sent to you that we've received. So our hope is just to let you all kind of have a discussion amongst yourselves. Feel free to ask other questions, of course. But once again, our goal right now is to just continue to hear ideas, to hear opinions about directions that CMS might head with regards to the chemistry tests that were at one point paid for using the ATP algorithm. So I will let you all go. Dr. Clark.
So I thought a couple things. I read through. Thank you for resending all those public comments. That was really helpful to be able to do that. And so I'll just do a couple quick comments, and then we could maybe go from there. So the one thing that I think was a theme in all the public comments was that there really wasn't any hard data to support the assertion that you're going to spend an increased $200 million, right? That was a projection of a worst-case scenario, right?
That was a projection, correct?
Yeah, so that was a projection based on very little data at the time, and so I think that's a challenge to sort of have a decision and make some policy decisions based on something where you're saying this might be the worst-case things that happened. But the other one I wanted to kind of get a sense of, and by the evidence that does exist shows that we are not unbundling tests. I mean, where there is data, it shows that labs are continuing to bundle tests the way that they are supposed to bundle those tests rather than unbundling them to retrieve profit. But the other thing I wanted to do is, so I try to pull some data, and since you guys actually work at CMS, you could support, or you could maybe give better sense. But I just did, from your website, the total healthcare spend was about $700 billion in 2017, and this is an increase of $200 million, which by my calculation is 0.02% or something like that, something really small. In terms of about a 0.02 increase in overall healthcare spending. I mean, it's a tiny little fraction, which frankly is reflective of the contribution of laboratory testing to begin with to the overall healthcare cost. It's not a huge chunk of it. And I'm not saying ignore the problem, but I'm saying if you take these two pieces, are you trying to solve a problem with this that doesn't really exist? In the absence of any evidence that the unbundling is occurring, and the absolute worst case scenario is close to, I mean, it's less than 0.1%, depending on how you do this. And so again, 200 million is a big number, and I don't think we should sweep it under the rug, but I think we also need to discuss it in context of overall delivery and not make some hard change that frankly could cripple a lab here or there or significantly impact our ability, particularly in a hospital setting, to provide services when it may not be necessary.
Thank you.
So this is Karen. I just want to check and see if Doctors Chandra and Baselski have any comments. And then if not, Dr. Bosler will speak. So I'm hearing none. Go ahead, Dr. Bosler.
Thanks. So the question that I had, kind of in follow-up to Dr. Clark, is, and something that we discussed at lunch, is when will we have data to know what the impact is? Because I think there were some cuts that were made to in the pricing for the actual bundled codes. And if laboratories are still using those bundled codes, presumably then there would be a decrease in expenses from that standpoint. So I'm just curious when you expect to have maybe the first round of data from claims to try to assess this better.
Right. No, and that's a very fair question. I think it's we have we only have initial data, so we don't have a complete look at what the effects and what the increased spending would be. So unfortunately, it's a fair point. We don't have that yet. Go ahead.
So I think, just, and this is the last one I'll do for a while, I promise. But I think that if you look at that, to build on Aaron's point in terms of, Dr. Bossler, sorry, the data that you're gathering here, we know that the cuts to those panels may be up to 30%, and those are some of our highest volume tests. And I can only speak for my lab, but I know it's representative of at least lots of hospital labs, which means those 30% cuts, again, are significantly impacting our ability to provide service. And I gave you guys a tour of our lab, and so you've seen what we have to do in terms of having the ability to have that 24/7 readiness. While it's a semi-production atmosphere, we have to provide those test results same day. And so, again, in this balance, and there's always a trade-off or balance. But I would say if you look at this, again, 0.02% increase potentially spend from your overall healthcare costs versus the 30% cut we're going to take on these tests, I can tell you that those hospital labs are going to be much more affected. And so if the goal is to drive more laboratory testing to the 2 or 4 national reference labs, I think this will have a great impact. If the goal is to protect patients and allow them to have the laboratory services they need, then I think this is really going to be problematic to address some, worst case doomsday scenario that's unlikely to happen. And I would just really encourage you to, make sure that you have not just early data or preliminary data, that you have robust data before you implement any additional changes that might cut laboratory budgets further than they're already being cut right now. And so I wouldn't do anything that would exacerbate, because you're already hitting a tipping point for many hospital labs that are outside of the big reference labs that may have the capability of absorbing those cuts. And so I think this could be really problematic, and I wouldn't do anything without being very thoughtful about it and having a lot more data to act.
So Sarah, I have a quick question. So Dr. Clark, I just want to make sure I understand, when you say panel, are you talking about the CPT panel codes, the codes where CPT created codes, or are you talking about what CMS used to do with its algorithm?
Self off. No, I'm talking about the disease panels like the CMP or the lipid panels and those existing panels that are not bundled after the fact, that are bundled ahead of.
So yeah, that's a great question. So none of these conversations would affect those CPT panels. If there's, but I think we're mixing.
No, we're not. I understand what you're saying. What I'm saying is that I know that's not going to change it, but those panels are already being cut, projections of 10 to 20% already, and based on some of the data that's existing, that reimbursement over 2 or 3 years is getting cut up to 30%.
Got it.
For those disease panels. That's number one. That's affecting us. But then on the back end of this, we're already using some of those panels and then billing in an ad hoc way. And we don't know. I'm not saying it would cut our reimbursement further. I'm saying we don't know. But if you have unintended consequences from this type of change combined with the changes we know are already in progress, that could be really, and it's not the type of thing that we can just reverse in 1 year, because large organization budgets, they don't change quickly. And if we have to cut people, or if we have to change the services we deliver or shift them to a reference lab, those don't come back in-house quickly. So any unintended consequences by these change, and we know there will be, there are unintended consequences from PAMA, right? And so I would just really say, let's not be quick to do a change, again, based on something that has little to no data to support it. It's a worst-case projection based on the assumption that laboratories are going to unbundle tests when there's no evidence that they're doing that. So
Well, and
don't
again,
rush to make a change.
The issue, I think I agree with you on the worst-case projection not being a good policy decision base. But I will say, just to clarify, on our end anyway, the worry is not for this like large mass unbundling. The worry is simply the discontinuation of the logic. So it's not, we're not speaking to a laboratory's behavior of surreptitiously, coming in behind and unbundling, because we agree. We have also in our initial data seen the same evidence that that at least, again, it's very preliminary, but that's not necessarily something that a policy needs to worry about. It's simply the discontinuation of the ATP logic behind the scenes and claims that we're talking about.
Sure. So, and I understand that you want to find a way to replace that because that was an efficient system that wasn't getting rid of it was sort of an unintended consequence of PAMA in and of itself. But what I'm saying is by going to this U-code system or some sort of tiered code system without having, again, robust data, robust simulations, and really understanding all the downstream angles, you could solve a problem or you could create a new one. And we've already got this existing problem that we're dealing with, and I can't imagine why, again, why there's a rush to do this when overall that worst case scenario is such a small percentage of the overall healthcare spend. I think you have the time to approach this in a thoughtful, rational, data-driven manner.
Understood. Thank you.
Sarah, I just want to confirm so that it's clear, at least for me. So, Dr. Clark, from what I'm hearing is you are agreeing with the public commenters that we should be cautious in creating new codes to take into account the efficiencies that had occurred when we had the ATP algorithm. And your concern is that until we look at all the potential positive and negative consequences that could occur should we institute those codes, that we should be careful before we move forward. That's
100% what I'm saying. Whatever you're proposing to do for the upcoming year, you should not do.
Okay. The second issue that you have is your concern over the current PAMA statutes for the AMA CPT panel organ disease panels and the cuts that are occurring as a result of that law. You're cautioning us to that with those cuts and the unknown effect of what could transpire if we were to create the codes, that there is concern on your part how that's going to hurt the labs even further.
Yes.
Thank you.
Yes, please. Dr. Schoonmaker.
I believe, I'm going through your slides here, I believe one of your options, or one of the recommendations I saw somewhere was in, again, delaying kind of making any changes until we could understand with some, or have some data to make a more informed choice. What do you see as the risk in doing that for next year or in the short term? Or is there someone, that could provide a response to that?
What's the risk in continuing to wait and continued monitoring?
From your perspective.
Yeah, well, I think worst case scenarios are exactly that, but they are usually rooted in some level of accuracy, right? So maybe not 200 million, but I would expect that there is some increased spending due to the loss of ATP logic. I mean, I think the table that we had before of the comparison between the ATPs versus what the private payer data is clear. So, I mean, there's a very boring answer of continued increases in spending. The extent to which that is true, you're right, remains to be seen, and I agree, does need data. It's a very basic answer, but would you add to that? I think there are pressures that Medicare can be, put under when that is happening, and that's the sort of beauty of work here is trying to figure out how to wade through the different perspectives of pressure. So I think that's a bottom line.
So we have Dr. Bossler and then Dr. Kroc.
So I'll show my ignorance here. I didn't read the GAO report. Did it happen to take into consideration the cuts that have been made to the other laboratory codes and the impact on savings versus what the concern about the increase in cost?
So I will admit that I am personally rusty on that because it was a little while ago, but I believe that their focus was at least trying to carve out just the effect of the ATP logic. There's other ups and downs in spending, I think, that are accounted to other unintended consequences, or intended consequences maybe, I don't know. But I believe that we're trying to, keep the conversation on the ATP logic. I think one of the things that we tried to clarify earlier this year was, again, what I started with yesterday, was really trying to separate this conversation, that there were some issues that had to do with the CPT disease panel codes and unbundling of those and that effect on spending, and then the conversation around the ATP logic, and they're distinct issues that that we really wanted to carve out. So I can't always speak to exactly what the GAO's methods were, but I believe at least the goal was to speak entirely around the ATPs. Say, Dr. Kroc?
This question is kind of for Sarah and the entire panel. With such a large increase in these, like say a Chem 20 panel, do you see that, or could you imagine that this drives utilization? So if you're a smaller reference lab or a small hospital lab, this might be one way to keep the doors open or the lights on, and ordering panel every day for every patient, one of those things. Because I come out of the tox field and we've seen some of the worst actors in that field, and just so long as we don't make this the big target. I mean, is that a concern you have? Does that sound like anything that could happen to other panelists here? That's just my concern.
So I want to make sure I understand your question, though. So are you saying that if the continued potential increase in spending does occur, that these would become even more of a target?
Increases utilization. So there are a lot of labs out there that have some sort of illegal agreement with the doctor, but in some way it benefits them to write for more tests. We've seen this in talks, for the last dozen years. Are we afraid we're creating the next potential? Does it drive utilization? Does the increase in cost increase the amount of times that these tests are run?
Right. I think we could, but I think that's something we can watch. I mean, we can see the utilization trends. We can see, when there are specific labs that, increase tests at a given moment in time. And again, I think what I agree, the data will be great once it's complete to look for those trends, and to see. I think, again, we're certainly trying not to set policy based on bad actors. I think that would be, at least in this situation, not what we're hoping to do. So I would say that's something we would continue to watch. Let's say Dr. Contis.
So again, I'm new on this panel. I'm just beginning to understand the complexities of coding, billing, et cetera. So I just wanted to voice my opinion, or my question really, concerning how does Medicare, or how does CMS, how do these payment codes reconcile rising costs in the laboratory themselves? In other words, costs which the hospital themselves can control, such as the price of reagents or rising prices of instrumentation.
Mm-hmm.
I mean, this is something beyond the hospital's control, essentially. Sure. And again, I'm not talking about buying in bulk and getting that reduction. But I think this is something we need to consider as well. And I don't know how it's reconciled with these rates, which if they decline, how does
Right.
one compensate for the
Right.
hard costs?
And I think it's a great question, and I'm going to just sort of totally put this disclaimer out that a lot of this is my Sarah Harding thoughts, and I know I'm the only one talking here, but I cannot promise that all of CMS agrees with me ever. But I will say that, I think that is something that PAMA did try to speak to on a whole, on a global level, in that, Medicare for existing tests is looking to private payer rates, which we would, we can only assume so much, but you would think are trying to take some of those increasing costs into account. Maybe they're not, I don't know. But I think that was one of the intended goals of PAMA, was to make sure that payment rates were reflective of the entire market. So again, I think where the challenge with these 23 chemistry tests for us is that for so long they were kind of governed by this really unique claims logic that kind of pulled them out of that sort of the rest of the CLFS space. And so this happened, which you see up on the screen, the difference in the rates. And so, again, but to kind of get to your question, for right now, for us to do nothing, these codes will once again go through the private payer data collection, and we will get those rates. They may go down. I don't know, because perhaps the private payers have adjusted what they're doing, perhaps not. But if we do nothing, we will continue to be reliant on what their data say.
Sarah, this is Karen. Dr. Clark, you had your placard up. Is there anything you would like to add?
I was glad to hear that you don't want to set policy based on bad actors, right? So as long as laboratories are following the correct coding principles, I think that the right thing will more often than not be done. So I think that that's a good thing. I keep coming back. I imagine that other committees or groupings within CMS are trying to do the same thing with imaging or anything else. So you're all working in the same thing. I guess I would really encourage you to think about it holistically, though, which is, if lab medicine, if you cut that across 30%, and it may seem like a big number that you're saving, but you're crippling labs and saving a fraction of the overall healthcare costs. And I think, from where I sit, and yes, it's because I'm in that field, we're really wary of the commoditization of lab results, right? That you're paying for numbers or positive negatives and reports, and that you're not treating it, not you specifically, but payers in general are treating it not as a service, but as a commodity, that if you buy in bulk, you'll just be fine. And that's going to be a real challenge. And again, this is not pivoting a speedboat. It's a big, ocean liner. And if you make these big cuts that change the way we deliver it, it's not going to be something that's easily fixed, and it will impact the way that care is delivered. And so, and again, while the absolute number in savings might seem big, again, you're not going to have any data on what's the impact of lack of access to testing in a hospital on clinical outcomes and how long stays are increased potentially, or how many additional adverse events. Again, those are all downstream unintended consequences that we may or may not know. And so, of course, every medical professional is going to advocate for their field not to be cut. So I get that. But I'm just saying, if you look at from the laboratory pathology, both anatomic and clinical pathology, the amount of the healthcare pie that we take up is relatively small. And I really would encourage you to think about it in the context of the overall delivery and the amount spent versus the value that's obtained. And I'm not going to cite figures because they're all over the map of how many decisions are based on lab data or not, and I don't think that's been rigorously studied. But we know people use this all the time. And I can tell you just from our laboratory, we're sort of, every few months we have to decide what services we can continue to offer and which ones we have to offload. And so, and this is continuing to evolve. And so it's just, again, it's really thoughtful. I know we're dependent on the data that you're collecting, but even there are large advocacy efforts from AACC, ACLA, et cetera, ASM, AMP that are encouraging you to get to be broader in your data collection so that it wasn't just from reference labs and POLs. You guys are clearly aware of this. And so the data even that you have to date is imperfect. So again, that's that final piece, is that it's good that you're not going to do it on bad actors, but I think you have to take the overall context into consideration when you're thinking about how you're going to change the system. And some of it you're bound by PAMA, I get that. But I think how you implement that, you do have some leeway within there.
Okay.
This is Pranil Chandra. Can I make a comment?
Yes, please, Dr. Chandra, go ahead.
Thank you. So I've been listening to all of the comments, and I just wanted to weigh in with some thoughts as well. I do believe that the context and data are both important, and I know this is something that's been echoed by a number of folks on the panel. With regard to the context and data, I think an important data point, and it may already exist. I haven't, excuse my ignorance, I haven't had the chance to dig into it, but I think it's important to assess, the entire, PAMA efforts here. What were the expected savings from, the implementation of PAMA in year 1, year 2, year 3, year 5? And what have those savings been, now that the data is coming back? So I do agree with the comments where the decisions have to be thoughtful, and you have to take into account all of the data and really look at it in the big context of things, and where the laboratory sits in the healthcare delivery process, and the role that it plays in driving medical decisions. And I think once you do look at the data and gather all of that data, I think you will then be in a position to make an overarching decision that balances what you all are trying to achieve is making sure that there's delivery of cost-effective healthcare, but at the same time there is delivery of high-quality healthcare important for our constituents and Medicare beneficiaries. So my 2 cents.
Great, thank you. Other comments or questions from the panel? So I don't know if this is a fair question to ask, but I can't quite help it. No, I'm going to withdraw my inappropriate question. Okay. Well, I think if there's nothing further, I mean, I really appreciate the comments. I know CMS does and will certainly take them into account. I think we'll make sure to continue to watch the data, to share that with you, to share it publicly. You know, I think one thing on the whole that at least our division has really tried to do over the past several years is to be much more transparent with the process of all of these lab codes and policies and everything that we do. So I think that will continue. And I don't think this will be the last time this group discusses this issue. So just consider yourself warned, but prepared too. So Dr. Carroll, yes.
It's on.
So I just want to pick up on a point that I think I heard Dr. Chandra mention, and it's really tangential to the issue, but I just want to put it out there. And that is, there is a national movement, at least among academic medical centers, to look at high-value care. Mm-hmm. And in the context of that, there have been several articles in JAMA that have addressed overutilization of diagnostic tests, not just clinical chemistry tests, but chest x-rays and things like that, such that I think the medical community is taking a look at overutilization of tests across the board. So I would urge CMS to just look at that literature, because it does emphasize the point that I think Dr. Clark was trying to bring up in terms of the contribution of laboratory tests to the overall healthcare expenditure, and what I think physician groups are trying to do in terms of looking more broadly with respect to overutilization of diagnostic tests. Excuse me.
Okay, thank you.
So Sarah, Dr. Schoonmaker, I want to get her comment, and then I just spoke with Sarah, and there's a few suggestions.
Okay.
So go ahead, Dr. Schoonmaker.
I noticed that there's a couple of the presenters here. Is it appropriate to ask if there's anybody in our Phone a Friend group here that had any comments in addition to what they had already submitted?
It is appropriate, and that was one of the suggestions from the division director. Before we go down that road, in view of the comments that we've heard, you will know historically that we did have an ATP subcommittee. And most of the folks who were on that subcommittee have, because we have rolling retirement, they have retired from the duties for this FACA panel. So what we would like to do is find out if there are those of you who would like to be a part of this subcommittee. And this will bring to CMS the added ability to hear more of your thoughts and comments. And then when the data does become available, we will be able to hear your input. So if you are interested in being part of the ATP subcommittee, what we will do is send an email out, and we will have you respond. And I think we are looking to get your input and meet sooner than later, but that has yet to be determined. So if there are no questions on that suggestion, I want to address Dr. Schoonmaker's request. And this is also coming from Sarah. So we have in the audience, I believe, ACLA, Dr. Quinn, and I don't know, and Dr. Adensky, who submitted public comments. So if you, the panel members, have any questions you would like to ask them, please put your placards up, and then we can make sure that these folks who submitted public comments can answer your questions. Dr. Chandra Baselsky, do you have questions for those who submitted public comments?
I do not. Thank you.
I do not.
Thank you. Dr. Schoonmaker?
Yeah, I would just reiterate, is there anything that may not have been included in the written comments that we should be considering after hearing some of the discussion here about
So
our
in order
concerns
to
about
have-
availability of data?
Yeah, in order to have order with who responds, so I'm going to start with ACLA because they presented. And so if ACLA has any comments relative to what was discussed here and not in your comment, what your comments are on that, so that we can get the other folks up to speak. Go ahead.
Thank you so much. I'm Julie Conley with the American Clinical Laboratory Association. I won't repeat what's in our comments. I think that they were.
Thank you. Hear me okay? All right. I won't repeat what was in our comments. I think they speak for themselves, that we feel there is one very clear and consistent way to reimburse for these codes consistent with PAMA. I do want to provide a little bit of context. Some of the questions that were mentioned about cost and savings and estimates and things like that. I believe it was mentioned, an important context is that the relationship to the ATP codes to the organ and disease panels, according to CMS utilization data, 96% of the volume of ATP codes goes through organ and disease panels. Those panels are facing some of the most severe reductions in PAMA of all codes, over 30%, almost upwards close to 40%, once those final weighted medians are taken into account. Really important context. Already PAMA, when you look at those overall savings, when you look at what the Congressional Budget Office estimated for savings, compare that with the savings in the final rule, and where we estimate, ACLA estimates those savings ultimately will be, we're at 4 times more than what the CBO ever estimated PAMA would save over 8 years. Looking at the final rule, nearly double what was estimated in PAMA savings. And then the last thing that I wanted to give, again, some additional context, when you look at and estimate those top 25 tests, some of the ATP codes, some of the organ disease panels are part of that top 25. Even with these changes, even with the variety of whether they were ATP codes or not, when you look at increases in spending for certain tests, overall spending for those top 25 tests from 17 to 18 will go down. The vast majority of tests on the clinical lab fee schedule, you saw reductions. That's just in year 1. And again, when we're looking at the most severe reductions, you'll see for this year and into 2020, very, very significant reductions overall. And again, very, very significant reductions when you look at those organ and disease panels specifically. I hope that provides that extra context to your conversation, and happy to answer any other questions. Thank you.
So I don't know if Dr. Adensky has any comments. That would be great. And then I know we had others who submitted comments. I believe it was ITSA, Dr. Quinn. I don't know if you want to follow up after Dr. Adensky.
Hi, Paul Rudensky with McDermott. I represent the Point of Care Testing Association, and we submitted one of the sets of comments in the book. One thing that, like Julie, not going to repeat, and I know that our comments were quite similar to ACLA's comments, but we have done some preliminary looks, and I don't have the data completed, but looking at utilization for, say, the top 100 codes that are primarily used in a point of care setting in 2018 versus 2017, and they are decreased. And so I think it is really important to look not only at what the overall pie is in terms of kind of what the expenditures have been, but also what the impact of PAMA has been, where the cuts have been, what that's done to utilization before we consider doing something else. I mean, PAMA, everyone knows there were many of us who worked on designing it. There were lots of things that you think about, and then there are things that were unintended consequences. This was not something that was consciously thought about what to do with the ATP system, but it is what is in what we have in the statute. So I think it is really important to be able to look at where we are in 18 and perhaps even where we are in 19 to see what the impact is before we would make another change that would cause dramatic cuts. Thanks.
So do we have anybody else who submitted a public comment who wants to answer questions from the panel? Dr. Quinn.
Hi, Bruce Quinn. I submitted a short comment, which you had the chance to read. And this is, I'm making this comment relative to the comments about the volume, which we don't really know. We don't have a lot of data coming in, as Sarah Harding said also. There were two truly separate problems here, which sometimes get conflated. One, you could have a known panel of 5 or a known panel of 12 and then unbundle it and get paid more. And CMS has put back in logic to prevent that. So that's a dead horse. And as Julie Connie just said at ACLA, 96% of these codes went through those named panels of 5 or 7 or 12. The other thing that I think is relevant is when you look at the ATP logic that we used to have and we had to take down because of PAMA, to me, if you had to take this ATP logic down because of PAMA, just reproducing it literally, but through a coding system, it just seems quirky to me that the ATP logic would be illegal, but exactly the same thing in codes would be legit. So that just seemed to puzzle me a little.
Any questions for these folks who have shared their public comments and concerns? Okay. Doctors Baselski and Chandra, any further thoughts based on what you've just heard?
None.
Okay, great.
None here. Thank you.
Okay. I just want to let the panel members know that Rashida is sending out through the CLFS email the suggestion or request if you want to be part of the ATP panel. So please respond. Dr. Bossler?
I just wanted to follow up with some questions on that, and that is, when would you anticipate having further discussions with that subcommittee and or having data to review with them?
I'm going to turn that over to Sarah and Sarah.
Yeah, that's a great question. And I don't know, honestly. And some of that is just from my own inexperience of like, you know, this is for me personally, new, you know, waiting for data to come through from a new payment system. So that may just be my ignorance. But I mean, you know, so I guess the question will be when we can share some of that data. I would expect that by the closing of the year, when the year is done, and we have data we can, you know, more consistently rely on.
So the subcommittee wouldn't get tapped into until maybe early next year?
Well, I mean, I think it does depend on kind of some of these continued conversations, and where this particular path for this year's conversation will go. And so I don't, you know, I hesitate again, just for me personally trying to pinpoint a timeline. But I agree with you know, that it would be useful to interact with a group, a smaller group, on a more regular basis, where you know, we can continue to explore some of the questions.
From a timeline perspective, is there a public comment period that's open right now for this?
So not right now. We opened a public comment period after the annual lab meeting in June, and that closed in July. So those are the comments you read. If we did move forward and posted, I think this was what we talked about yesterday. If we did move forward and post something on the preliminary determinations, then yes, there would absolutely be a public comment period along after that. And they would be, any new proposed codes would be treated like any other new HCPCS code. It would be, there would be a public comment period, there would be a final determination, there'd be a reconsideration. At least, again, that's how I understand it to be. So, just to give you an idea.
Thanks for clarifying.
Yep. All right, so Sarah, any other issues you, regarding the the automated test panels discussion?
No, this has been very helpful. Thank you.
Okay. So I just want to do two things. One, go over what's left for the FACA panel members. So those of you who are participating in the ADLT subcommittee, so we have 2 more quarters left in the year, so potentially 2 more meetings to review ADLT applications. If you are interested in participating, please let us know. We are always happy to add more members to the ADLT subcommittee that reviews the applications. The second thing is just reminders for upcoming activities outside of the ADLT, and obviously potentially it will be working on the ATP subcommittee if they choose to have a meeting sooner than later. And then finally, I just want to thank you very, very much. You put a lot of time into reviewing the codes even before the meeting occurred. I also want to thank those of you who were the chairs who pulled together the new members, and the new members who dove in and set up SharePoint sites, worked behind the scenes to get things done. I just want to thank you very much for that. You can see how efficient this meeting was because of your time spent. And then finally, I want to thank again the public who did take the time to travel. This is not an easy thing to do. And we greatly appreciate the input we're getting from the public. So having said that, I'm going to formally adjourn this meeting. And thank you very much for the attendance on everybody's part.